Hello, everyone, and good morning. I am Luis Sanchez, and it's my pleasure to introduce the first session of the day. And we have the honor of presenting the Hafnagel Sisters and Dr. Washek here. We are grateful to be joined by these wonderful people who have contributed so much to OB anesthesia. Dr. Suzanne Hafnagel is a clinical professor of anesthesiology and obstetrics and gynecology at Thomas Jefferson University, where she subspecializes in obstetric anesthesiology. She teaches anesthesia residents, medical students, and student nurse anesthetists daily in the operating room and on the labor and delivery floor. She is a chairperson of the Awards and Honors and the Scholarly Activities Committees and is a member of the Board of Governors for the American Osteopathic College of Anesthesiology. Dr. Hafnagel will be speaking today on select SOAP consensus statements, so please give a warm round of applause to Dr. Hafnagel.
Good morning. Hopefully everybody is all awake after that Let's Go Crazy Prince song. And I'm going to go through some select SOAP consensus statements. Now, SOAP is the Society for Obstetric Anesthesiologists and Perinatologists, which is the main society for people that do OB anesthesia. I have no disclosures. My learning objectives are I'm going to talk about neuraxial procedures in obstetric patients with thrombocytopenia. I'm going to spend more time with that. Then I'm going to speak on management of pregnant patients and postpartum women with thromboprophylaxis. And I'm going to go through a little bit on that, but I'm just going to say right now that basically the guidelines are the ASRA guidelines on the COAGS 2.9 app, so I'm not going to spend a lot of time on it. Those guidelines are going to be in this lecture for completeness, but there's a couple other things I want to talk about in that lecture, and then I'm going to finish up with the association of epidural analgesia with autism. First of all, what is a consensus statement? Because that's where these came from. It's developed by an independent panel of experts, usually multidisciplinary, and in this case it would be obstetric anesthesiologists, perinatologists, and obstetricians. And the purpose of this is a task force is convened to look at all the literature and synthesize the most recent data and make a practical algorithm that we can use to help take care of our patients. It is a systematic review of the literature and questionnaires and something called a modified Delphi process, which was alluded to in one of the lectures yesterday by Dr. Grenda. This is how a lot of societies make up these guidelines. And I'm going to show you a picture of that, but we're not going to go into that in any detail at all. It's not intended to set a legal standard of care. It does not replace medical judgment, even though a lawyer can use this in a suit against you. But again, you're free to use your own judgment. It's just guidelines. It is not intended to ensure any kind of successful patient outcome, nor is it to guarantee a specific outcome. And these guidelines are revised every so often when new data is available. That's just a schematic of a modified Delphi process where you have a couple phases. It all goes into the final analysis. So the first one I'm going to talk about is the SOAP consensus on patients with thrombocytopenia. These are the authors. It is an ANA 2021, that is the cover and the journal. And I don't know if you can see it, but the lead author is Melissa Bauer. She is at Brigham and she is an osteopath. Yay. About 12% of OB patients have thrombocytopenia if you use the definition of less than 150,000. However, only about 1% have moderate to severe disease, which is less than 100,000. Some of the etiologies include gestational thrombocytopenia, immune thrombocytopenia, thrombocytopenia associated with hypertensive disorders like preeclampsia and HELLP syndrome. Acute fatty liver of pregnancy can also cause thrombocytopenia, and TTP. Now, this is just a table in that journal comparing them in an algorithm form, which some people like, and it goes through some of the etiologies and some of the diagnostic criteria for them, which we're not going to go into in a lot of detail. What is a workup going to consist of when someone has thrombocytopenia? Well, it's nice to have a platelet count before and then during pregnancy to compare the difference. You're going to ask about a bleeding history, including heavy menstrual bleeding, postpartum hemorrhage in a prior pregnancy, any kind of bleeding from major or minor surgeries. A lot of epistaxis not during pregnancy, it's more common during pregnancy. Easy bruising. And a family history of bleeding disorder is really important because a lot of these patients that have thrombocytopenia, it can be a genetic thing. Now, what about thrombocytopenia-related complications and neuroaxial anesthesia? The incidence in the OB population is calculated to be 1 to 200,000 to 1 to 250,000. And that's with the definition of 150,000. But what is the incidence when in severe thrombocytopenia less than 100,000? We really don't know. There was a meta-analysis that was done in Journal of Clinical Anesthesia in 2020. It looked at the years of 1947 to 2018. Now, these were heterogeneous patients, not just OB patients, but they did split this up. There were 33 spinal epidural hematomas, and more of them came from spinal taps because there are larger needles used with that. They were split into different platelet counts and the incident or the number. So you can see that the most common are going to be very low platelet counts, only 4 in 76,000 to 99,000. Now they split it up into OB patients, and there were only 5 reported in OB patients. The platelet counts varied from 44,000 to 91,000. There were 2 after epidurals and 3 after spinals. We're going to go into that a little bit more carefully. So of the epidurals, patient number 1 had hemorrhage and a coagulopathy. The catheter was accidentally pulled out when the platelets were only 58,000. But this patient, although she had some symptoms, did not require surgery. Patient number 2 had preeclampsia. The platelets were 71,000, and her complaint was that she was not moving her legs. So she did go to surgery, and only 4 milliliters of a clot were removed. Now, we all know that we put certainly a lot more than that into the epidural space when we're doing a blood patch. Now, of the spinals, patient number 3, which is the first patient of the spinals, had preeclampsia. The platelets were 66,000. That patient was also found to have an AVM, and she did require surgery. The next one with the spinal had HELLP syndrome. The platelets were 44,000. This patient did not need to go to surgery. And the final patient had platelets that were 91,000, but they dropped to 26,000. She did develop some sensory deficits, but no surgery was necessary. And this falling platelet count is really an important thing. We're going to touch on that in a little bit. What are some of the presenting signs and symptoms of spinal epidural hematoma? Lower extremity motor deficit is the most common. Back pain is second. And then you can see some of the others. Bowel and bladder dysfunction is about third. 95% of patients are symptomatic within 48 hours of these, so that's a really good thing because you really need to know early to hook them up with an MRI and get a surgical consultation. Some of these deficits can become permanent between 6 and 12 hours after development, so early diagnosis and treatment is important. So what is the risk of spinal epidural hematoma in OB patients? And we talked about complications, the ones that we've seen already. What then translates to the risk? There was a study of 1,500 OB patients that had thrombocytopenia. And again, these are patients that these were all comers with thrombocytopenia with the definition of 150,000. None of these patients developed hematoma. And this was a study from Anesthesiology in 2017. So Lee, the lead author, estimated the upper limits 95% confidence interval by platelet count, and this is how he estimated it. You can see that under 50,000 had an 11% incidence or risk. It didn't actually happen. Whereas 70,000 to 100,000, it's only 0.2%, and that's an important number, 70,000. Then there was a more recent study in 2018 in Iowa that added another 471 patients. Again, none of them developed it, but they added that data in, and it makes our risk here even a little bit better. But you still have 9% when they're less than 50,000, but 0.19% with 70,000 to 100,000. Should we be getting laboratory values to try to assess a bleeding risk? Well, a CBC is going to give you an absolute platelet count, but that can be low with clumping, lots of different things, and that doesn't tell you the bleeding risk. It just tells you the absolute platelet number. A PT-PTT is going to test for factor deficiencies, which is not going to really predict bleeding in women that have thrombocytopenia. TEG and ROTEM show the viscoelastic properties of blood clots, but there's not really a big correlation in platelet counts unless they're less than 50,000. A PFA tests a platelet plug formation, and you get something called a closure time. That's going to be abnormal with several different things, including thrombocytopenia, anemia, and a qualitative platelet defect, but again, does not correlate with the degree of bleeding risk. And there's something called a platelet aggregation test, which tests agglutination and aggregation of platelets in response to certain agonists, and there aren't any studies in OB patients to validate this. So what does the consensus statement say? It does not recommend routine use of these tests to determine safety of neuraxial anesthesia. Now, that doesn't mean you can't get them. You can get them to make you feel a little bit better about it, but the routine use of all of these tests is not recommended by the SOAP consensus statement. This is an assessment table in algorithm form in that article of what I just went over. Some people like to put these out on boards or whatever because you can see it in a more condensed form. Now, should we be giving platelet transfusion before neuraxial procedures? Some recommend prophylactic transfusion before an LP if the platelet count is less than 50,000. Now, there was a Cochrane review, and this was in 2018, and there was no evidence from randomized controlled trials or non-randomized studies to determine a platelet transfusion threshold prior to placing an LP or an epidural. And there's certainly risks to platelet transfusion, transfusion reaction, trolley, and TACO, although they're more common with a lot of blood transfusion. And how much does that raise a platelet count in the first place? 1 unit, and I don't mean pherese platelets, I mean 1 unit of platelets can raise a platelet count 5,000 to 10,000, whereas a bag, which is usually pherese platelets, about 5 units, can raise it 30 to 50,000. ACOG does recommend platelet transfusion in a patient that has preeclampsia with active bleeding or if they need to go to C-section to raise that count above 50,000. But again, there's not a recommendation here for putting a regional in. What about thrombocytopenia and aspirin therapy? ASRA guidelines say that nonsteroidals and aspirin do not increase the risk of spinal hematoma, but these are in patients with normal platelet counts. And what exactly does aspirin do? It irreversibly inhibits cyclooxygenase, reducing platelet aggregation for the life of the platelet. However, a platelet lifespan is only about 10 days, and the half-life of aspirin is 20 minutes. So if you form platelets after that 20 minutes, they're going to work okay. And you only need 20% normal platelet activity to have hemostasis. So these are all good things. ACOG now is recommending 81 milligrams of aspirin a day for patients at risk for preeclampsia, and that's a lot of patients in my practice. So what do? There was a study back in Lancet back in 1994 called the CLASP study. This looked at 1,400 pregnant women, and they were given 60 milligrams of aspirin daily. Now, not necessarily thrombocytopenic, but they were given aspirin. And what did they see? They found no epidural hematomas with the aspirin, and they also looked at PFA and TEG, and those were all normal. Again, we're not recommending those tests. So that is some evidence that, I know we're giving a little more than that there has not been a problem. But you should have shared decision making if a patient is on aspirin and is very severely thrombocytopenic, because again, this CLASP study, they had normal platelet counts. So these are some of the recommendations. You really need to use the clinical context here. And you have to include all the comorbidities and the airway, if you need to go to a C-section, what are the risks of general, and what does the patient want? Does the patient want to take that risk? And you go over all of that with the patient. The risk of spinal hematoma is lower with the spinal than an epidural because it's a smaller needle. And although I showed you more spinals than epidurals in the earlier study, that was just in a big wide range of patients. But in general, it's a smaller needle. So if you're looking at doing an epidural versus a spinal for a C-section, spinal is going to have a less of a risk because it's a smaller needle. So the threshold platelet count is 70,000, and that's the number that I use. Again, you have to take it into context. So this consensus statement divides it into two different categories. Those with known thrombocytopenic etiology, they've already been worked up, so we're pretty comfortable with that. And then you have patients that have an unknown, or it's a new one. So these known patients are what I alluded to before: ITP, gestational thrombocytopenia, hypertensive disorders of pregnancy. Those with unknown etiology, knew this pregnancy, we're going to go through that. So with the known etiology of pregnancy, you're going to ask if there's a bleeding associated with that thrombocytopenia. That's an important question. And then make sure that this diagnosis has been confirmed. And if you have a concern for a history of bleeding or DIC, then certainly avoid the regional. But in patients with platelet counts 70,000 or greater, the risk is very low of spinal epidural hematoma. 50 to 70,000, you got to assess the risks and the benefits. And then less than 50,000, there is definitely an increased risk. So should you avoid it? Again, the clinical context, I probably would avoid that. A falling platelet count, as I alluded to in preeclampsia, is an ominous thing. And that is a situation where it's probably more reasonable to get a platelet count and put your regional in close to the time that you had that platelet count, because it can go down significantly in a short period of time. And also consider an early regional in those people before the platelet count falls. Now, what about unknown etiology? I'm going to tell you right now the recommendations are basically the same. These are going to include thrombocytopenia in the antepartum period, new thrombocytopenia, or you didn't have a platelet count prior to pregnancy to compare it. So again, same thing. If you're concerned for a disorder of hemostasis or DIC, avoid the regional. If the platelet count is less than 70,000, a further workup is necessary. It would be great, but you probably wouldn't have time to do that if she comes in labor. But 70,000 or greater, even though you don't know the etiology, it is a low risk of spinal epidural hematoma. This is a decision-making table in that article in algorithm form of what I just said. Again, it's in this lecture for completeness. And then I'm going to go through a couple practical strategies. Dr. Bauer was at our SOAP meeting in May in 2023, and she gave a couple recommendations that are not in that article. She felt that you should have an experienced provider place the regional, especially in someone with severe thrombocytopenia that is at risk for spinal epidural hematoma. She suggested the lateral position because then you're minimizing vessel engorgement. You don't have gravity working against you. However, you may have worse landmarks, and in this era where we have a lot of supermorbidly obese patients, as my sister's going to talk about in a little bit, if your landmarks aren't that great, then that may be a problem as well. She suggests fluid predistension, meaning pushing some saline through that epidural needle to push the vessels out of the way prior to doing like a CSE or threading your catheter to try to minimize it puncturing a vessel. And she also suggested using wire-embedded catheters. Wire-embedded catheters are more pliable, minimize paresthesias, and minimize perforations of the dura and epidural vessels. But unfortunately, to my knowledge, you have to use a 17-gauge epidural needle to put them, and with our teaching institution, that would increase our incidence of spinal headaches and the need for blood patch. So we are not using wire-embedded catheters because we're still using 18-gauge epidural needles, but we do have a soft flex tip catheter. It doesn't have a wire in it, but it's supposed to do a little bit like what she's recommending here. And she also says limit the depth to about 6 centimeters in the epidural space, because the more you put in, the more it's going to encounter a blood vessel and poke through. And with our catheters, they're close-tipped on the end, so it's easier to puncture a vessel. With anything, you need a quality assurance and improvement recommendation. So it's really important, again, to know the etiologies of thrombocytopenia in pregnancy, and early consultation with us and hematology if there's enough time to be able to figure out what's going on. There should be pathways at your institution for patients that have suspect spinal epidural hematomas, because again, they need to get urgent studies and maybe go to surgery so you don't have permanent deficits. There should also be a national or international registry to catalog patients that got neuraxial procedures that are thrombocytopenic, so we can get better numbers for our risks to tell patients. All right, next one I'm going to talk about is the consensus statement on thromboprophylaxis in patients on anticoagulation. And these are the authors. They are also SOAP members. Lisa Leffert is up at Brigham as well. And this is from ANA in 2018. And again, I am going to go through more about a couple things with this, and I'm going to show the guidelines, but we're not going to dwell on them because they're on that ASRA Coag app, which is, I'm sure everybody has here. It was the best $2.99 or $3.99 I ever spent on an app, because I can't remember this stuff. That is the cover and the article. Venous thromboembolism is a leading cause of maternal death in the United States, and it is increasing. It accounts for 2.9% of maternal deaths. These are some of the reasons why it is increasing. And because pregnancy is a hypercoagulable state, that puts us really behind the 8 ball. And there are also physiologic changes of pregnancy that modify drug pharmacokinetics, and I'm going to talk about heparin and low molecular weight heparin and this in a little bit. But differences in volume of distribution, clearance, bioavailability, and drug metabolism are some of the reasons. So thromboprophylaxis is a key preventative measure, and we're going to see, and we're seeing more and more patients coming in on thromboprophylaxis. Now, there are no cases of obstetric spinal epidural hematoma after a neuraxial procedure in a survey that was done between the years of 1952 and 2016, and this is from Anesthesia and Analgesia in 2017. So there was a statistical risk, and it is between 3 and 4 in a million obstetric cases. So that's really good. That's pretty low. Why are there some differences here? Pharmacokinetics of unfractionated heparin differ between pregnant patients and non-pregnant patients. There was a study in American Journal of Obstetrics and Gynecology back in 1995 where a single weight-based dose of 9,500 units of sub-Q heparin was given to patients, and pregnant women showed that they have a lower peak plasma heparin concentration, shorter times to peak concentration, and the concentration was only 55% of that of non-pregnant patients. And with this dose, there was no increase in the PTT, or there was no increase in the anti-factor 10A levels either. Another study in 2002 also corroborated this, and it showed that plasma heparin concentrations corresponded to a lower PTT, and these were some of the reasons. Increase in binding of nonspecific heparin neutralizing proteins, and there's an increase in factor VIII and fibrinogen levels when you're pregnant. And unfractionated heparin requirements also are variable, especially with advancing gestational age. So you really don't know what the heck to do here. So that is why low molecular weight heparin is the drug of choice now in pregnant patients for VTE. It is because of some of these: better bioavailability, better safety profile, and more predictable dosing. Pregnancy, though, does change the pharmacokinetics of low molecular weight heparin also. In a study of enoxaparin, the volume of distribution and clearance increased during pregnancy, and the anti-10A level was lower, and there were lower peak plasma levels. And the other low molecular weight heparins pretty much are the same. How can we assess this risk of spinal epidural hematoma, or assess the coagulation status? There is no standardized test that will assess the risk for giving neuraxial anesthesia. There's no data that correlates the PTT or anti-10A assay or point-of-care testing to the spinal epidural hematoma risk. With low molecular weight heparin, in general, the recommendations are wait the prescribed time interval, and there is no recommended lab test like an anti-10A level that should be done. And it's also unknown what residual anti-10A level is safe to provide neuraxial anesthesia if you even got the level. With unfractionated heparin, because there's so much variability, we recommend waiting a time interval, but also getting a test, the PTT, and the therapeutic index is also more narrow. So you wait the time and you get a test for unfractionated heparin. And protamine, if you need to reverse it, you don't need as much protamine to reverse low molecular weight heparin, but how much is what you need? Nobody really knows that either. So antepartum recommendations, you need a standardized protocol. you need a pre-delivery anesthesia consult so we know that there's a patient on thromboprophylaxis, and we also need to know if it is okay to withhold anticoagulation. So we need to know the reason why the patient is on anticoagulation. You need good communication with your OB and the patient because there are wait times for both of these. Within patients, they can also have mechanical thromboprophylaxis, so most of these people are going to be on low-dose unfractionated heparin. Whereas outpatients, they're going to be on low molecular weight heparin. They're usually transitioned to unfractionated heparin at about 36 weeks because the wait time is less. And if you're on unfractionated heparin greater than 4 days, you should check a platelet count to make sure they haven't developed HIT. Intrapartum recommendations are there so that a patient can get a regional. With unfractionated heparin, again, I'm not going to go through all of these. It is just the ASRA guidelines, even though these are pregnant patients. In general, low dose is going to be 5,000 and you're going to wait 4 to 6 hours or assess coagulation. Intermediate, you're going to wait the time 12 hours and get coags, and high dose, you're going to wait 24 hours and get coags. Whereas with low molecular weight, low dose, it's going to be 12 hours wait, and high dose or intermediate dose, it's going to be 24 is what I use. For urgent procedures, again, exactly the same. And I'm going through this. I don't expect you to read this. It's on the ASRA guidelines on that app. Same thing with emergent procedures. But assess your risks and benefits here because you don't have time to wait. This is just in that article, and it's in algorithm form for both low molecular weight, and one was heparin, this is low molecular weight. It's a little bit easier to see it this way. Again, thromboprophylaxis in the postpartum period, this is only here to complete my lecture if you want to look it up, but I'm not going to go through all of these. It's all, again, on your guidelines app. Now, certain circumstances, a patient is going to be bridged with unfractionated heparin before low molecular weight heparin, then you go back to the unfractionated guidelines. And sometimes a lot of pregnant patients are going to be on nonsteroidals, especially after a C-section. So that's another issue. There aren't a lot of guidelines when someone has thromboprophylaxis and nonsteroidals, so consider holding the nonsteroidals, but you can keep the acetaminophen because you can have an increased risk of bleeding when you're on nonsteroidals. Again, quality assurance, same thing as before. You need to know how to report and to identify these patients, know the signs and symptoms. We went over that with the thrombocytopenia, same thing. Because, again, you need to get them diagnosed very quickly so that they can have decompressive laminectomy if they need it. And err on the side of being conservative because these complications are really significant. However, sometimes the risk outweighs the benefit if there's a bad patient with a bad area or whatever. Now, the last thing I'm going to talk about is association of epidurals with autism. Why is this even a problem? These are the authors, and this was in a study in JAMA Pediatrics in 2021. But why did it come about? Well, we'll get into that. What is autism spectrum disorder? It is a complex developmental condition, results in impairments in social interaction, speech, repetitive behaviors, things like that, and it does seem to be increasing in the United States. Some of the potential causes you can see here. C-section is even in there because sometimes someone needs a C-section because there are risks with the baby, any kind of risk with the baby leading to neonatal vulnerability will increase can increase the risk of autism. But what about epidurals? And why is this even an issue? Because of this article. This came out in JAMA Pediatrics in 2020. It was a population-based cohort. There were 147,000 live births in California that were looked at, and epidural analgesia was associated with a 38% increase in the risk of autism spectrum disorder. The biologic plausibility was questioned in this study because the risk estimates they didn't take out for residual confounding, and I'm going to show you that in a minute, but it was way distorted because there are other factors that can influence the outcome. I alluded to a few of those, and I'm going to show you more in the next study. But of course it created apprehension with us, with the patients, and how would that make someone feel who's already had an epidural and they have a child who has autism? So the rebuttal study came out by these SOAP authors, and this was in JAMA Pediatrics in 2021. It was also a population-based cohort from Manitoba, Canada, so a big geographic area. It included all singleton births in a hospital from 2005 to 2021. It excluded C-section because the need for C-section can also increase the risk of autism. The primary outcome was diagnosis of autism after 18 months of age. These are the covariates. Look at all of them there. Now, these things have to be considered. Some may not have an impact, but some definitely can. And this study looked at that and took it into account when they did their statistical analysis. So the results. Final analysis was over 123,000 births. The offspring were followed for almost 8 years. Births exposed to epidural analgesia were more likely to be nulliparous, have preterm rupture, have antepartum hemorrhage, induction of labor, augmentation of labor, and fetal distress. So these people already were at risk for these problems or had these problems and got an epidural. That's not a cause and effect, it's an association here, so this has to be taken into account. The age of diagnosis was 4 years, and the results. The risk of autism was 2.1% with those exposed to epidural analgesia and 1.7% without. So, epidural analgesia for labor was not associated with autism. Now, the unadjusted analysis for covariates did show an association, just like that first study. But when you adjust for these things, that association was totally eliminated. The strengths are that this was a contemporary cohort over a large geographic area. They did make limitations saying that they didn't have any information on how the epidurals were dosed or how long they were in, but I seriously doubt that's going to make any difference. So the bottom line is, epidurals are not associated with autism. So in summary, there's a low risk of spinal epidural hematoma when performing neuroaxial procedures when a platelet count is greater than or equal to 70,000 and there is no other disorder present. Pregnancy is a hypercoagulable state. That's good for us. And just follow the ASRA guidelines for peripartum patients, even though the ASRA guidelines don't say specifically for pregnant patients. This consensus statement says yes. And that is the COAGS 2.1 app, which again, I look at it every day. And lastly, epidural analgesia for labor is not associated with autism spectrum disorder. Thanks for your time. Now,
Thank you, Dr. Hufnagel. And now we're going to present Dr. Jane Hufnagel. She's currently the Director of Obstetric Anesthesia at Thomas Jefferson University and has obtained the rank of Clinical Professor of Anesthesiology in Obstetrics and Gynecology. She trains medical students, anesthesia residents, and student CRNAs on a daily basis and was awarded the Faculty Teaching Award in 2003 and 2008 for her contribution to residence education. She has many abstracts, presentations, publications, and 8 textbooks chapters to her credit, mostly in the field of obstetric anesthesia. Today, she will be speaking on obesity, and not just obesity, I guess, super morbid obesity. So please join me in welcoming Dr. Jane Hufnagel.
Thank you for that kind introduction. I'm going to try to go a little quicker. I may go a few minutes over, but our next presenter assures me that's just fine with him. So today we're going to talk about obesity and pregnancy. I have no conflict of interest to declare. My learning objectives are, at the end of this presentation, I hope you will understand the physiologic changes of obesity and how they affect pregnancy, the potential issues that the obese parturient and her offspring will face, and the specific anesthetic considerations in the obese and supermorbid obese parturient, although I know you know some of these. It's just kind of a review, and may shock you a little bit. So as we all know, there is an obesity epidemic in our country right now. It's getting worse and worse. In 1 year alone, over 36% of childbearing age women were obese. This led to 300,000 preventable deaths per year, mainly due to the comorbidities associated with obesity. However, the C-section rate is also higher in these patients, and we have trouble with their anesthesia. I have listed the WHO classification of weight status, so we'll be looking at patients whose BMIs are over 30. That is the rule on our labor floor rather than the exception. Many times we will have 3 or 4 patients on our floor at a time that are BMIs of 40, 50, 60. So less than 30 is the exception rather than the rule. Starting with some physiologic changes of obesity. Pulmonary system, there's a higher energy expenditure due to this increasing BMI. Oxygen consumption and CO2 production are increased. Minute ventilation has to increase to deal with these respiratory demands. The weight of the chest wall is higher, so the work of breathing is more. And this is even further if you're pregnant. Normally, frequent shallow respirations are more efficient, except in pregnancy when the tidal volume increases from the hormones of pregnancy. All the lung volumes you see here are decreased in our obese parturients. The FRC is decreased, and it may be below closing capacity, especially when a parturient assumes the supine or the Trendelenburg position. This leads to airway closure, especially during tidal ventilation, and can lead to decreasing oxygenation, which I have on the next slide. Chest wall and lung compliance are decreased, but the airway resistance is increased. So again, ventilation is usually in the more compliant, non-dependent part of the lung, whereas pulmonary blood flow is in the dependent part of the lung. And when you lay supine or in the Trendelenburg position, leads to VQ mismatch and hypoxemia. There's a higher incidence of sleep apnea in our pregnant obese patients, and this increases their risk for hypertension, MIs, strokes, diabetes, metabolic syndrome. There's also a higher risk for preeclampsia and eclampsia in pregnancy, cardiomyopathies of pregnancy, and pulmonary embolus. There's 5 times higher chance of dying in the hospital during your pregnancy and delivery if you are obese. Moving to cardiovascular system, the blood volume and the cardiac output are increased, usually due to an increase in stroke volume, a little smaller increase in heart rate. Preload and afterload are increased. This leads to eccentric and concentric LVH, and diastolic relaxation is certainly impaired in these patients. The pulmonary blood volume is increased, and it may lead to pulmonary hypertension in some of our obese parturients. The incidence of hypertension is 3 times higher if your BMI is greater than 30 during pregnancy, and even more so in the supramorbid obese parturient. Aortocaval compression is greater when you lay flat if you are morbidly obese. There's a 12 times higher incidence of mortality, showed one study in ages 25 to 34 if you're obese. And there's actually 2 cases of cardiac arrest when a morbidly obese parturient was placed supine without a wedge under the right hip immediately due to compression of the IVC and decreased venous return and cardiac output. LVH is higher. Cardiac enlargement. There's 30 times higher incidence of PVCs in our obese parturients. They think it's mainly due to fatty infiltration of the right ventricle and the conduction system. What about GI changes? Historically, and this still holds true with our obese parturients, there's a higher gastric volume and decreased in pH, especially when they're laboring, especially when they've had opioids and going on to have a C-section. The rate of gastric emptying is controversial, and now we believe that the gastric emptying is probably the same, but the intestinal transit time is slower and the esophageal peristalsis is slower. The incidence of hiatal hernia, therefore, and reflux is higher, and this can lead to an increased risk of aspiration. Gestational diabetes and overt diabetes are more common due to insulin resistance. What about coag changes? My sister said something about this. There's a higher risk for thromboembolic complications when you're pregnant, but when you're obese and pregnant, it's even higher. Impaired fibrinolysis, there's increased platelet aggregation and activation. The production of coagulation factors is ramped up. Our obese parturients don't want to move around a lot. It's hard for them to do that. That increases their chance of getting a DVT. And they have a higher incidence of operative delivery. Also, surgery increases their chance of DVT. Moving to interaction with pregnancy. So in general, median weight gain, and this was years ago, in pregnant patients who are obese was at least 30 pounds. But 20% of them gained more than 40 pounds. Some may not look like they gain a lot because they're already pretty obese, and those patients may not gain quite as much. It still is a strain on their system. There are more prenatal tests, ultrasound exams, meds, prenatal visits, you name it, in our morbidly obese parturients. They have more high-risk pregnancies. As I said, they go on to have a C-section more often. And when they're in the hospital, they are in longer than our non-obese parturients. ACOG recommends when you see an obese parturient, see how obese they are. What is their BMI? Do they have high blood pressure? Do they have diabetes? What are the comorbidities associated with this? It'd be great to have preconception weight counseling, but most of our patients come to us already pregnant and obese. So that's really not an option for us. So what are some potential risks in the antepartum period? They have a higher incidence of early pregnancy loss, type 2 and gestational diabetes, but also gestational hypertension. Higher incidence of indicated, and this is medically indicated preterm delivery, baby's not doing well, mom's not doing well, and spontaneous preterm birth of our extremely preterm babies, 22 to 27 weeks. Some of them will also have a higher incidence of postterm delivery. Multifetal pregnancies, usually dizygotic twins. I thought this was interesting. They think it's due to increased FSH levels. And again, as you would expect, a higher incidence of OSA and carpal tunnel syndrome. What about intrapartum? There is a higher risk for needing an induction of labor, and when you have an induction, of failing that induction and going on to have a C-section. The mean duration of the progress of labor is significantly longer in our obese parturients, and they have a higher risk of failing a trial of labor after cesarean. But we have trouble with their anesthesia, and it's not our fault. There's more attempts at epidural placement. When we're trying, we get wet taps more often in them because things don't feel right. If we get a catheter in, it may fail more times. When we dose a catheter that's in the right place, sometimes we have more hypotension. And if we can't get a catheter in, they have a more difficult airway if we need to have a cesarean delivery. Also, complications of macrosomy. These babies can be big because mom has diabetes associated with her hypertension, with her obesity and hypertension. This leads to shoulder dystocia. They have a higher incidence of dysfunctional labor, which can lead many times to an operative delivery. If they deliver vaginally, they have a higher incidence of genital lacerations, and both types have a higher incidence of postpartum hemorrhage. What about the postpartum period? Well, DVT is the biggie here. And the incidence is higher with increasing BMIs. There's also a higher incidence of infection, partly due to diabetes. C-section wounds are infected. If they vaginally delivered and need an episiotomy, those wounds get infected, and endometritis. And there's a higher incidence of postpartum depression. What about in the offspring? There's a higher incidence of congenital anomalies in these babies. There's a higher incidence of stillbirth, perinatal, neonatal, and infant death. Prematurity, as I said, because of the medically indicated preterm deliveries and the spontaneous delivery of our extremely preterm babies. Also large for gestational age due to concomitant diabetes, shoulder dystocia, and obesity in later life. There's a higher incidence of asthma, thought to be due to changes in inflammatory pathways and dietary exposures of mom. The incidence of childhood obesity here is 2 to 3 times normal in our babies of our obese parturients if one parent is obese. If mom and dad are both obese, this goes to a whopping 15% or 15 times higher, and I am just blown away by this. These babies also have an association with higher incidence of cognitive impairment, autism spectrum disorders, ADHD, anxiety, depression, and certainly eating disorders. And it's interesting, and I don't know why, but the risk of CP is higher, probably because birth trauma is a little bit more common, and childhood epilepsy. The most important maternal issue that I can tell you today is that obesity increases the risk for death during pregnancy. One study actually showed greater than 50% of women who died during pregnancy were overweight or obese. Moving to analgesic management of labor and vaginal delivery. When we see our obese parturients, we need to see what comorbid conditions they have. Do they have diabetes? Do they have hypertension? And you don't want to tell somebody that they're hypertensive and treat them that way if you are not getting an accurate blood pressure. So the blood pressure cuff has to fit the patient. The length of the cuff must exceed the circumference of the arm by 20%. There are conically shaped blood pressure cuffs available that can fit the upper arm better. We don't have any of those at Jefferson, so we can use a smaller cuff on the forearm. Get a little higher pressure, but because it's a little... What's going on? This isn't touchscreen. Could somebody show me how to get rid of this? Please? I don't know how to cancel this without maybe just... Sorry, that just came up. Oh, there we go. Sorry. Sorry about that. I did nothing. Sometimes they're so obese. You may need to place an arterial catheter, and I have actually had to do that. You'll need longer spinal and epidural needles because you probably won't, some of our patients will not be able to use the ones that you normally use. You'll need larger, excuse me, labor beds, transport gurneys to get them around the hospital. OR tables have to, mostly they exceed 500 pounds. You have to place the patient in the middle of the table, or it has to be centered. The pedestal has to be centered. Otherwise, it can tip when you get your patient on the OR table. Certainly extra personnel to help them move. They are not really willing to move a lot themselves, and they're really heavy. IV access may be difficult, so ultrasound is a really great skill that I don't seem to have, but we have a lot of people at our department that do, and so they help me out on a daily basis. So what about analgesic choices? Well, the one that I least favor but isn't listed here first because I don't want you to use it if you can avoid it is systemic opioids. Causes maternal respiratory depression, neonatal depression. Sometimes it may be all you can get. What about a pudendal? Well, I can't get an epidural. The OBs can do a pudendal. Well, the patient may not be able to even get her legs in stirrups. The landmarks might not be there, so the OBs may not be able to do a pudendal. What about inhalational analgesia? Here I'm specifically talking about nitrous oxide. Now, we don't have that at Jefferson, but if you do, just know that your obese parturients may, when they use the nitrous oxide, have an unexpected loss of consciousness that you don't see in your non-obese parturients. It is limited availability. It doesn't do a lot, but it may be the only thing you have if you can't get a regional in the patient. So obviously neuraxial is the best choice. You need good analgesia to facilitate an atraumatic vaginal delivery, and that is what you want in these patients. You want a vaginal delivery. A C-section, although more common, is really a nightmare in some of them. Macrosomia is common. Shoulder dystocia is common, so you need a good working epidural. So what about lumbar epidural analgesia? It will reduce the oxygen consumption and the CO2 increased cardiac output that we have in our laboring patients when they're laboring. It will allow an extension of the block when the more common C-section is called on these patients. But you may not have the ability to get an epidural in, or it may be very difficult. You can't feel her spinous processes, so you don't know where midline is. There is a greater depth from the skin to the epidural space. If you place your needle slightly off midline on the skin surface, when you finally get to epidural space, it may be way lateral, and you don't realize that. And when you thread your catheter, you'll have a one-sided block. Not what you want to hear. Fat pockets and softer ligaments will lead to false loss of resistance, so you may not be sure where you are or whether you're even in the epidural space, and this leads to more attempts and an accidental dural puncture rate that is higher than our non-obese parturients. One study in the literature actually shows the initial failure rate of an epidural in these obese parturients is up to 42%, and a second or third catheter is often required. The first one doesn't work, it's one-sided, it pulls out just with a little movement. So how to succeed? Place the patient in the sitting position. Now, she may say, I can't get up there. If you try her on her side, gravity will not help you. You will not be able to feel spaces, and this will be an exercise in futility unless you are superhuman. So I say sit her up. This will minimize the distance from the skin to the epidural space. Now, there is some suggestion in the literature that a cross-legged sitting position may open the spaces better. And you think, well, she can't get in that position. You'd be surprised at what these patients can do if they're motivated for an epidural. Alternatively, you can put a stool in front of her so she could rest her feet on the stool if she can't get them up on the bed, but sort of at a position where they're almost crossed. It seems to open the spaces better. One ultrasound study actually showed that. We're thinking of starting a study like that at our institution. We just haven't got it through IRB yet. You can look at C7 in the gluteal cleft and see if you can draw a line parallel to that. It might give you a little better idea of where midline is. You can ask the patient, where do you feel the needle? Is it right? Is it left? Is it midline? I used to think that was nothing, and that actually works. So my residents taught me something. And ultrasound may help you find midline. I don't think it does much for depth, but I think it will help you find midline. It's helped me a couple times. When you dose the catheter, there's some suggestion that because the epidural veins are engorged, that what you put in there may go higher, faster, or at least cover more segments. So you want to dose slower. Your goal is excellent pain relief, minimal motor block, because you want her to have a vaginal delivery. The literature says the epidural must be bilateral and near perfect, and that means you have to round on them, frequent intervals. If they're starting to become one-sided, fix them or replace them. It's the last thing you want to do and the first thing you absolutely have to do, or you will be left with a big problem. And I don't mean that figuratively. Other neuraxial choices, combined spinal epidural. This will give you rapid onset of excellent pain relief, and it will give you a higher chance of success. What is going on here? Higher chance of success with the epidural part because you've seen CSF when you put your spinal needle in, so you're at least pretty sure you're midline with the epidural. Problem in our obese parturients is you may not have a needle combination that will fit the patient, and therefore a CSE you'd have to do with 2 sticks. You're not going to get this advantage of it then. Likewise with the dural puncture epidural. It's the same thing as a CSA, but you don't inject anything into the intrathecal space. There is some suggestion, though, when you dose the epidural, that there is some translocation of the epidural medication into the CSF, gives you a little bit better block, especially in the sacral segments. A continuous spinal catheter is an option. Now you're putting a big epidural needle in there and you're putting a 20 gauge catheter in, but it will give you a better way to extend the block if a C-section is called and an urgent section, which happens a lot of times. But you say, well, I don't want to have to put a blood patch in her. Good news is the literature shows that the incidence of post-dural puncture headache is a bit lower in our obese parturients. The increased intra-abdominal pressure from the pannus, baby and pannus, and then pannus after baby's born, will push on the epidural space and sort of discourage CSF leakage. Moving to anesthetic management of cesarean delivery. In general, our C-section rate is at least 48% in our obese parturients if the BMI, if they are over 300 pounds. There's a higher maternal risk, morbidity, fetal injury, anesthesia-related death, as I showed before. Airway problems are there, difficult or failed laryngoscopy or intubation. The breasts are engorged. The AP diameter of the chest is higher. She's got fat pads on the back of her head, so sometimes you can't get the head extended enough to get a laryngoscope in. When she lays down, the head won't hit the pillow because of the fat pads, so it makes her airway difficult. You may not be able to find the cricoid cartilage if you are doing a general anesthetic for cricoid pressure, or God help you if you need a cricothyrotomy and jet ventilation. Positioning, the ramped position, and I have showed here with tails under the head and the shoulders. It will align the oral, pharyngeal, and laryngeal axes. This might be a good position to put your patient in, even if you've placed a spinal and you lay her back, because she may be able to breathe a little bit better this way. But certainly ramp her if you are going to do a general anesthetic. When you lay her flat, you need to put a wedge under the right hip immediately, as I talked to before, because otherwise the pannus may absolutely cut off the IVC. Decreasing venous return, hypotension, cardiac arrest. The OR table has to support her weight, and you will need lateral extenders because otherwise the pannus may hang over both sides. Now, what about that pannus? It needs to be retracted for a C-section, and many of our OBs used to tape it over the shoulders. Now, our patients can't breathe when they lay flat to begin with. And then you tape the pannus over the shoulders, and this can lead to hypotension, they can't breathe, fetal compromise. A cephalad, vertical suspension, or lateral retraction is better. If they tape the pannus lateral, they can't get close enough to do the surgery. So we have a system in our hospital now, it's called a Traxi. It is an adhesive system that they put on the belly, it doesn't tape anything up over the shoulders. And I thought, how can this work? And I did a BMI of 60 on Thursday, and they put one on. And I went around to look, because I'm usually not going around to look to see how well this is working. I mean, it really works. I was astounded. Didn't mean they took any less time to do this C-section, but it still gave them access better when they're doing a low transverse incision. And that incision, many times a supraumbilical incision may be preferable because a low incision will then be covered by the pannus later, and I'm sorry, I don't know why this is doing this, and get infected. If you have to do a general anesthetic, the aspiration risk is higher because they may desaturate very quickly and you'll have to ventilate. When you ventilate, you probably have difficulty and get the stomach full of air. So you want to give them sodium citrate before you go back for any section, whether it's general, whether it's regional, because anybody can go on to have a general anesthetic. This will increase the gastric pH in 5 minutes, but it only lasts about 60 minutes. So if you don't give something else, the section will take longer than an hour. They will still be at risk at the end of the section for gastric acid aspiration. So if you have time, an H2 receptor antagonist and metoclopramide are indicated. What about spinal anesthesia for a C-section? Well, may be difficult. You need a longer spinal needle. Again, you may not be able to identify midline or even the level that you want to go at. There is some suggestion that there will be unpredictable cephalad spread. The CSF volume is decreased, the epidural veins are engorged, pushing on the CSF. It will go higher faster. So is your level predictable? Little concerning there. When you lay the patient supine after your spinal's in, and this is really interesting and I never thought about it, their buttocks have so much adipose in them that they are actually in a relative Trendelenburg position even though the table is level. And that can cause the spinal to go higher. This is really most important in our supermorbid obese patients. Respiratory function will be impaired more in these patients with a spinal, but it gives you a denser block. It may not last long enough for these C-sections. Many of them last longer than 2 hours, and I can tell you that ours do. So it is recommended to do a continuous technique in our obese and supermorbid obese parturients. That is either a CSE, combined spinal epidural, a spinal catheter where you dural puncture them on purpose and place an epidural catheter. I have listed a double catheter technique. This is an epidural, but it can be done with a spinal in our obese parturients. You do the epidural catheters, one thoracic, one lumbar, and then you can do a spinal or just use both those catheters. And they can help you get through this and keep one catheter in for post-op pain management, but many of these have a supraumbilical incision, and they won't be comfortable with just a lumbar catheter. What about epidural analgesia? Reasons for this over spinal? Well, you probably already have it in because they're in labor. So that's good, and it's working if you're doing your job. The duration of surgery will be greater than 2 hours, so you can extend this block, and you can titrate it slower when you initiate it, so you can minimize the problem of a high spinal going really high quickly in these patients with a very bad airway. Cardiopulmonary function is impaired a little less because the block is not as intense as a spinal. And it may be easier to do. Some people feel it's easier to do. The feel with an epidural needle is a little bit better with a spinal. Again, ultrasound may help you. And if you have an epidural in, you can use it for post-op pain. General anesthesia. Well, obviously, you're going to need to put an endotracheal tube in this patient, and this is more difficult in our obese parturients. So you need an experienced assistant to help you, and I don't mean a first year who's the first day on OB. You need somebody that knows what you need before you have to ask for it. You need appropriate equipment. Short-handled laryngoscopes to get them in because the breasts are engorged, multiple blades, various endotracheal tubes, LMAs if you have a problem that may get you out of a problem, glide scopes, or McGrath's, any kind of video laryngoscope, cricothyrotomy, jet ventilation, and a fiber optic scope. We have those all in our C-section room. And sometimes you have to do an awake fiber optic or an awake intubation, whether a direct laryngoscopy, whether video or fiber optic, and sometimes the patient will refuse. So induction, therefore, is a rapid sequence. Their hypoxemia is faster onset if they are obese. So I recommend, and we don't have the high flow nasal cannula at the prior lecture at our conference suggested would be great. But what I can do, if there's time, put a nasal cannula and just crank up the flow underneath your tight-fitting mask. And this may help the time to desaturation be a little longer when you're struggling to get the tube in. What about drugs? Propofol Anthipentol, which we don't have anymore in this country, both cross the placenta. You should dose those based on lean body weight. Succinylcholine is best to use 1 milligram per kilogram of total body weight. Rocuronium, you dose it based on ideal body weight. You will have a prolonged duration with 1.2 milligrams per kilogram, but bear in mind, Sugamadex at 1.2 milligrams per kilogram reverses a high-dose rocuronium in 2 minutes. There have been no major abdominal or neonatal effects with this, but you dose this based on ideal body weight plus 40% or the formula that I have there. Still, inadequate reversal has been seen with Sugamadex, but use it if you have to. Many times you're using it to get out of a problem because you can't get a tube in and you didn't use Sux. Maintenance volatile agents, plus or minus nitrous oxide, if she will tolerate nitrous oxide. Some of them desaturate so quickly that that isn't a possibility. The volatile agent will accumulate in the fat, so I really only use it until baby's out, and then I switch to Tiva with propofol. You will need, try an FiO2 less than 0.8 to minimize atelectasis. Increase your respiratory rate. We don't have an A-line in usually, but we want the PaO2 to be 30 to 32. So that accomplishes this with a tidal volume of 6 to 8 mLs per kilo of ideal body weight. Please put on PEEP, and you probably will need recruitment measures during this 3 hours plus C-section. Wake the patient up when they're fully awake, they're coughing on the tube, they can squeeze your hand. You have completely reversed their muscle blockade. And I sit them up a little bit to try to decrease the diaphragmatic compression so they can breathe a little bit easier. Moving to the super morbid obese parturient. These are BMIs over 50. The highest one I have had in our institution is 83 for a 4th C-section. There's not a lot of literature on this. There are several case series, one with a BMI of 73. I'm like, yeah, that's small change, with a BMI of 76. And the one that curls my hair is a case report of a BMI of 109. She was presenting for her 4th C-section. Her 3rd C-section, she was a good bit lighter. She came, they put a spinal in her. When they laid her down, she had a cardiac arrest. They thought it was due to a high spinal, but in reality it was just due to severe hypotension that they kind of didn't recognize. There's a ghost up here, something. So she refused a spinal. She refused a regional at all. So they had to do a general anesthetic. Now this astounds me. She was 316 kilos. That is almost 700 pounds. They did a modified rapid sequence induction. They used 500 milligrams of propofol, 350 milligrams of succinylcholine, and it required 2 attempts at intubation. I just can't. I don't know if her tubes were tied. But the supermorbid obese parturient requires risk stratification. See what comorbid conditions they have, because they're all there and they're all worse than our obese parturients. They may need PFTs, an echo. Do they have pulmonary hypertension? How bad is their OSA? What about other things? Transportation and hospital equipment. Ambulances may, with the personnel in the ambulance, may not be able to accommodate their weight. Elevators in your area where you're taking care of these patients have to accommodate 6,000 to 6,500 pounds. You need bariatric wheelchairs, 48 inches wide with a 6-foot turning radius. I am not doing anything here, I swear. Beds must accommodate 600 to 1,000 pounds, and they really need pressure redistribution, air surfaces. The patients won't move around a lot, and they will get bed sores. The doorways have to be over 3 feet wide. You need equipment to lift them, bariatric lifts, either portable or ceiling mounted. What about bathrooms? Toilets cannot be on the wall. They have to be on the floor. Otherwise, they will break off when the patient sits on them. Usually stainless steel is used with about a 5,000 pound capacity. You need grab bars because they're not steady on their feet, heavy duty sinks. OR equipment, you need a bariatric surgical table that accommodates 600 to 1,000 pounds. You will absolutely need side extensions because the pannus will fall over the sides. Extra long compression devices for the lower extremities, safety belts, extra long instruments, deep retractors, and above all else, extra personnel to help you move these patients. You'll have difficulty with IV and invasive monitors. They are even worse than our morbidly obese. These are super morbid obese patients. A vaginal delivery may not be possible. The pannus is very large. Their lower extremities are swollen. They won't move around. The OBs may not be able to get to the perineum, so they may not be able to have a vaginal delivery. Epidural placement will be difficult. It may dislodge if you get it in the right place. You have to place it early, and as I said before, evaluate it often and replace it if you need to. C-section rate is over 50% in the super obese parturients. The OBs may not be able to monitor the fetal heart rate due to the pannus. Stat C-sections may be limited or impossible, and I tell my OBs, this is not going to happen. I'll move as fast as I can, but I can't kill mom for this. Skin incision, we talked about with the morbidly obese patients. A transverse incision will be better for wound strength, decrease postoperative pain, but the infection rate is too high, so most will be supraumbilical. Better access to get the baby out, better post-op wound care, but there's more pain with it, and there's a higher incidence of dehiscence. And antibiotic dosing, all these people will need 3 grams of Ancef because they're really going to be over 120 kilos. Redose if the surgery is greater than 3 hours, and it will be, and blood loss is more than 1,500, and it will be also. So key points here: coexisting disease complicates obstetric and anesthetic management of these obese and supermorbid obese parturients. The obese parturient is at risk for obstetric, anesthetic, neonatal, surgical, and postoperative complications. The most important thing here is airway complications during induction, emergence, and postoperatively constitute the most common cause of anesthetic-related maternal death. Place the epidurals early, round on them often, and replace them as soon as they are not pristine. And that's the last thing you want to do, but you really have to. And the supermorbid obese patient, all the physiologic changes of the obese parturient are accentuated here. Her comorbid conditions are more, and they're worse, and their risks are higher. So you need appropriate equipment to deal with these patients and personnel to help you move them around. And I thank you for your attention and whatever this ghost was doing up here. I don't know. Thank you.
Thank you, Dr. Hefnagel. Next is Dr. Sean Washek, who will be speaking in postural puncture headaches. Dr. Washek is an anesthesiology and educator at Thomas Jefferson University in Philadelphia, Pennsylvania. He pursued his Doctor of Osteopathic Medicine degree at Lake Erie College of Osteopathic Medicine and undertook his postgraduate training in anesthesiology at Thomas Jefferson University Hospital. He has been involved in various practice-based critical projects, including his involvement in the development of the Jefferson Anesthesiology app and his co-directorship of the Anesthesiology Coagulation Laboratory. Please join me in welcoming Dr. Washek.
All right. Good morning, everyone. I kind of wanted him to just say, this is Sean, and he's going to fill up the rest of the time. But anyway, I'm honored to be speaking here in front of you today. I do have to thank Dr. Hufnagel, Susanna, and Jane, number one, for teaching me how to do epidurals, and number two, for guiding me through the whole academic process of this. So the title of my talk is Post-Oral Puncture Headaches, Oh No, Not Again. Number one, how can we talk about this anymore? Number two, that's what the Hufnagels would always say when I would come back into the resident room, and I would tell them I wet tapped someone once again. But this is always a headache to ourselves and to our patients for a couple reasons, right? So it's a complication that's specifically caused by us, and oftentimes it requires an additional procedure to correct it. So it's always an interesting conversation when you go up to the patient and tell them, you know the thing that I just caused? Well, we just have to do it one more time. And if that doesn't work, well, we'll just do it again. But trust us, it will eventually work. And oftentimes it does, but there can be a chronicity to these headaches, which can cause significant morbidity to our patients. And as we will discuss later on, there's a mounting body of evidence that shows the headaches are not always self-limiting as they're described. So I also have no conflicts of interest. However, I would like some. So if anyone has any high income, low type of work, please let me know. So this is a loose outline for our talk today. So we'll touch briefly on the incidence of post-oral puncture headache, diagnosis and treatment, gold standard versus conservative treatment, not directly comparing them, but basically just seeing what else is out there. chronic headaches due to post-dural puncture headaches, and then the dural puncture, epidural, and post-dural puncture headaches. So my first brush with anesthesia was when I was a first-year medical student and my wife was laboring with our daughter. So the anesthesiologist walks in very calm, collected, and preps and drapes, getting ready for the epidural. And 5 seconds later, he's asking about her scoliosis that he sees, as he's looking at her spine. So she starts to tell him, oh, it was discovered when I was, 5, 6 years old, yada, 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 essentially. And by the time she finished, the epidural was already in. So like all of us, sometimes you just got to push the propofol or just put the epidural in. So before we kind of get into the up-to-date research, I always find that it is fascinating to kind of look back to see where we came from. So where do we need to start? Well, with cocaine, of course. So the anesthetic oops, sorry, that's the wrong guy. So the anesthetic properties of cocaine were discovered by Dr. Kohler in 1884. He was an ophthalmologist. So a short time after that, an American neurologist named James Corning set about to see if the anesthetization of the spinal cord was possible. However, in the description of his technique, there we go. I fixed it though. In the description of his technique, no CSF was noted, so what he likely did was injected the medicine into the epidural space. So the first actual spinal anesthetic is attributed to Dr. Beer. So this was a fascinating story. Basically, he convinced his friends to achieve spinal anesthesia on each other, and what they did was they took hammers and hit each other in the shins and then put cigars out on each other. Kind of reminds me of this guy here. So if anyone doesn't know, this guy achieved spinal anesthesia on himself and basically saw how far he could run. Unfortunately, it didn't make it into the movie, but maybe you could publish it in a medical journal shortly. So after Dr. Beer, so Ferdinand Kaplan was the first one to actually describe the thoracolumbar and was the first intentional, oh geez, here it goes again. Do I need an access code to connect to this or just cancel? All right, good. So he was the first intentional administration of I think we're good, yeah. The first intentional administration of epidural anesthesia. So he introduced caudal blocks for mainly genitourinary procedures. So Fidel Pages was the first one to describe a thoracolumbar approach to epidural anesthesia, finding the epidural space through subtle tactile distinctions within the ligament. The first continuous epidural was performed by Manuel Caraballo in 1947. A small catheter was inserted and a giant ovarian cyst was removed. However, the first report of continuous epidural anesthesia for the obstetric patient was by Charles E. Flower from Johns Hopkins. Now that the brief history lesson is over, let's get into the exciting stuff, the complications of our specialty. So as we mentioned before, Dr. Beer was credited with the first spinal anesthetic, but what he's also credited with is the discovery of a spinal headache. So as they were doing this, basically everyone let massive amounts of CSF recede from them as they were injecting the anesthetic, and the next day, Dr. Beer called out of work because his spinal headache was so bad, and the younger guys actually showed up though. But they also had severe headaches. So this was the first reported case, essentially, of spinal headache. So post-dural puncture headache is a major complication of spinal anesthesia or inadvertent dural puncture during epidural anesthesia. So the incidence of accidental dural puncture is quoted somewhere between 0.7% to 1.5%, depending on the study. And 60 to 80% of these patients develop post-dural puncture headache. It can cause significant morbidity, however, is generally described as self-limiting. So how do we diagnose these headaches? So diagnosis is generally a clinical diagnosis. Imaging studies oftentimes don't provide any additional information. If the patient has the characteristic symptoms, most of the time we just assume that's the case. So it's described as a bifrontal or occipital headache that's exacerbated in the upright position, and there's symptom improvement in the supine position. There can be associated neck pain, dizziness, nausea, and tinnitus. On physical exam is usually unremarkable. However, in rare instances, there can be a palsy of cranial nerve 4. Now, I knew exactly what cranial nerve 4 was and what the palsy looked like. I'm sure all of you do as well. But just in case, because I actually had no idea. So the right fourth nerve is the trochlear nerve. So what does it cause if there's a palsy? Basically, the patient will experience double vision, and there will be a turning up and in of the affected eye. Basically, there's an inability to gaze downward and inward. So the occurrence of post-dural puncture headache is caused by CSF hypovolemia and a decrease in the pressure due to the leakage of CSF out. So the larger damage, obviously, the more that comes out. But we can see that with very small insults to the dura, there can even still be a post-dural puncture headache. So the headache can occur even if you lose as little as 10% of the total volume, which actually is a fairly small amount. So one of the mechanisms that's thought to cause this is that basically by the decrease in the CSF, what you have is venous engorgement and then sagging of structures, and this causes stretching of meninges, various cranial nerves, as well as the venous engorgement itself causes this pain sensation. So basically all of the structures of the brain kind of sink to the occipital orifice. So as we said before, it's generally considered a clinical diagnosis. However, there are specific findings that you can see on MRI if for some reason it was unclear. So these basically include, like we said, sagging of the brain to the occipital orifice. There's pituitary enlargement, and sometimes there can be subdural fluid collections. In intracranial hypovolemia, the loss of the buoyant force of CSF and venous engorgement, as well as sagging of the brain, leads to traction, like we said, of the cerebrum, the cerebellar veins, meninge, and cervical nerves. This is what we believe leads to the headaches. However, there's also another mechanism that suggests that this sagging of the brain can also cause the release of neurotransmitters, specifically orexin from the hypothalamus, which can contribute to the headaches as well. All right, so treatment. So basically we all know that the standard treatment, conservative epidural blood patch. So we're going to talk briefly about conservative treatment. We won't go into too much about the epidural blood patch because we all know it works fairly well. But we will offer some additional treatments if your patient does have chronic headaches or if the blood patch just for some reason doesn't work. So let's talk about conservative treatment first. So we've established that there's a hole created in the dura and fluid comes out. So let's see if we put fluid back in, maybe that would help. So this is one of the conservative measures that's oftentimes taken. And now fluid going back in isn't obviously directly back where we're losing the CSF, but a lot of people will advocate for either intravenous or oral hydration. So this was actually looked at. So Dietrich and Brandt performed a prospective study of 100 neurological patients who were undergoing LP. One group was instructed to drink 1.5 liters per day. One group was instructed to drink 3 liters over the following 5 days. Basically no difference. Now obviously this isn't comparing IV versus oral or even putting saline back into where CSF should be. However, there's really not much data to back up oral hydration. So what about flat bed rest? So we know that if the patient sits up, the headache's worse. So what if we just lay them flat for 24 hours? Well, this was also looked at. Basically same thing, 100 patients were randomized either to be mobilized immediately or 24 hours flat bed rest. And same thing, basically no difference at all in those two groups. What about the last one? So we all know we're all drinking coffee this morning. We know that it causes vasoconstriction. We all have caffeine headaches if we don't drink our coffee. So let's give the patient IV caffeine. And there's actually a decent amount of case reports and case series. However, most of these actually quote a study that was performed in 1975. And this study was actually looking at IV caffeine. So the same thing, we're randomized to 2 groups after patients that were undergoing LP. However, the study was small. It didn't control for risk factors. It didn't quantify the amount of caffeine that was used before. And there was crossover between the experimental and control groups. So overall, a pretty poor study. So what does all of this tell us? So basically it tells us that for conservative measures, there's really no data to support using those conservative measures. However, as we did mention early, these headaches are generally considered to be self-limiting, so a period of watchful waiting is probably okay. All right, so why do we care about post-dural puncture headaches? How many times can we talk about this? So they are generally self-limiting, and we have a treatment for them, right? It's all true, but there are a subset of patients that do develop chronic headaches. So in the general population, chronic headaches occur in 1 to 4%. There's approximately 39 million people in the United States and 1 billion people worldwide. Of patients that are seen in a headache clinic, 40% of those patients are actually diagnosed with chronic headaches. And the prevalence is 3 to 5 times higher in women. All right, so the ICH-D3, which is by far my favorite volume, the International Classification of Headaches Disorders, it describes post-dural puncture headaches as those that remit spontaneously within 2 weeks. However, we do have a reasonable amount of literature all the way back as far as the 1950s that describes chronic headaches after spinal anesthesia. So Van Dam and Drip's cohort study looked at roughly 8,000 patients that underwent a total of 10,000 spinal anesthetics, and 1,000 of these patients developed headaches. 20% of those patients had headaches lasting 14 days, and 4% had headaches exceeding 7 months. All right, so what if we look at the literature as a whole? Well, someone else did this for me, so it was great. So Zhang and colleagues performed a review of the relevant literature in 2022. So basically, they included articles that tracked accidental dural puncture as well as chronic headaches from 1974 to 2022. Among the cohorts, the sample size basically ranged from 40 to 11,000, and 11 out of the 12 cohorts looked at the obstetric patients who had accidental dural puncture as well as post-dural puncture headache after an epidural anesthetic. So one of the cohorts actually included patients that had a diagnostic lumbar puncture. So what did it show? So basically this is just running through all the studies here, and it shows the relative risk on the right-hand side. So there was a positive association between accidental dural puncture and chronic headaches. So the pooled relative risks of the chronic headaches in 15,000 patients in these studies with an accidental dural puncture was 1.9 at 2 months, 2.5 at 6 months, and 3.6 at 12 months. So let's specifically look at one of these studies that was performed. So Ansari and colleagues out of Stanford performed a prospective study looking at headaches after accidental dural puncture. Basically, they enrolled 99 patients and matched those who had an uncomplicated neuraxial anesthetic with those who had a dural puncture. The primary outcome was prevalence of disabling headache between the two groups. So the disabling headache was defined as a headache that limited you from working, studying, or doing something that you needed to do. And basically what was nice about this study is they actually looked at those who had headaches prior to pregnancy as well as those obviously after the dural puncture. So it was roughly the same percentage between those two groups prior to the dural puncture, and then after the dural puncture there was an association between the dural puncture and chronic headaches. So the primary outcome was looked at 2 months. However, it still was statistically significant at 6 months. It did devolve a bit after 12 months, however. So what else? So we mentioned blood patch. So we all know the first treatment is conservative and then blood patch if need be. So how does blood patch affect the incidence of chronic headache? Well, it's kind of a mixed bag. So there were 7 studies that actually did address this question. However, most of it was just using secondary analysis. It wasn't the primary outcome in any studies. And pretty much it was a mixed bag. Some showed it may have helped, some showed it didn't. So basically we just need to continue to look at this. So despite a great number of successful cases with the epidural blood patch, specifically in those with chronic headaches, there are several reports of the epidural blood patch failing. So in a lot of these cases, the CSF leak was actually discovered to be ventrally as opposed to dorsally. So there are some other things that we can actually do to help these patients. So one that's described is fibrin glue injection. So most of the data for this comes from case series, and it is in patients that had chronic headaches and who failed multiple blood patches. Now, the volume that was injected was 3 to 5 mLs, and most patients saw significant improvement in their symptoms directly after the procedure. All right, so this one is an odd one. So if your patient has chronic headaches, so in this specific case report was a patient who had an accidental dural puncture. The symptomatology was postural initially, however, years later it was non-postural and basically just seemed like it was a headache, but they were still attributing it to the dural puncture initially. So someone performed a greater occipital nerve block and the patient received greater than 50% reduction in headache intensity. Now, I had no idea what it was, so a greater occipital nerve block is basically, the nerve is located 1/3 of the distance from the occipital protuberance to the mastoid process. The nerve can be found by palpation of the artery. It was generally described as a blind technique. However, it is a volume block. So when you look at the case reports on it, there are 1 to 2 instances of coma, and it's most likely because of intraarterial injection. Someone didn't aspirate enough or thought they were where they weren't, and obviously the medicine didn't go where it was supposed to. So what else can we do? So surgery is a viable option when the leak can actually be identified. So there was a case series that looked at roughly 9 patients who underwent surgery, but this was when the exact leak was known and the exact spot was known. And what they found is that in most of the patients that required surgery, they did have a ventral leak. There was one patient who actually developed a CSF venous fistula, which was also repaired. But these patients ended up having complete resolution of their symptoms. So it's just always something to at least look out for if our patients keep coming back or if the blood patch doesn't work initially. So the last thing that we're going to touch on is what Dr. Hufnagel alluded to earlier, the dural puncture, epidural, and headaches. I think it's always reasonable to mention the complications and benefits of something that we're going to perform, specifically when we're looking at the chronicity of headaches that can be caused by puncturing the dura. Now, what does the literature say about headaches and dural puncture? Basically, there's no difference. We know that we're using a very small needle, and most likely it's not going to cause anything, and the data has actually shown this as well. So as she said earlier, it was first described in the obstetric population by Thomas. However, this was performed earlier by Suzuki. I believe it was in Japan. So we know that the dura is perforated with a small spinal needle, and the hope is that there's translocation of that local anesthetic to help with the block. Now, there was actually a nice infographic in anesthesiology basically looking at all of the studies to date. And I do think it's worth mentioning, like we said, there's no increased risk of headache. However, what are we doing this for? So basically, it did provide some faster onset of the block, depending on the study that you looked at, and maybe a bit of a denser block in the sacral area. However, this is also kind of a mixed bag when it comes to the data. So where do we go from here? So this probably isn't going to change much in anyone's practice day to day. However, I do think that patients need adequate follow-up, and I do think that we need to establish some sort of referral system if patients do develop chronic headaches. So the take-home points for today, again, like we said, adequate follow-up in patients with an accidental dural puncture, correct referral for those with chronic headaches. However, we can also provide patients some sort of hope as well. If you do have a chronic headache, there are some additional treatment modalities that we can try or at least refer you to so that you're not going to be stuck with this your entire life. And again, additional research needs to be performed. However, this likely isn't going to change anyone's practice day to day. Thank you, and my daughter and my dog thank you as well.
Well, thank you to the Thomas Jefferson gang. Do we have any questions for these wonderful people?
But I've not done a Dexter and patch over myself. Saline sometimes works in the intrathecal space if you know you have a catheter and it's in the intrathecal space. Give 10 cc's of saline before you pull the catheter. There's a couple articles that say that will help, and it seems to, so we try to do that. Again, I haven't followed patients on a regular basis to know if the headache comes back. We just follow them to make sure. So intrathecal may work better. I feel like probably not.
Yeah, I'm just wondering, I was referring to like an epidural, continuous epidural saline.
Yeah.
Oh, I've not tried that. I've not tried that.
Just to equalize.
Just keep in mind, and that would be okay as long as it's continuous.
Right.
Epidural catheters left in a long time with local. Local's bacteriostatic. Saline, not so much. But again, if it's moving, we don't see that there'd be a big problem.
Yeah, we've never done it, but I always thought about doing it. We just thought maybe there was some research on
We
it.
have one thing in. Okay. Okay. The gentleman in blue, please. Why don't you just yell at us?
Is it?
We'll hear you.
Okay. In the first lecture, if you have a patient with declining platelets and you place the epidural, afterwards, when you go to remove, do you ever have to transfuse platelets to be able to get to a point where you can remove the catheter? I mean, we were talking about keeping patients too long. I mean, typically our vaginal deliveries are discharged day 2. If we have to wait because we can't pull the catheter, that's going to be problematic. What is your strategy there?
It's a falling platelet count from the development of top syndrome, which is what it usually is. The nadir usually happens between 24 to 48 or a little bit later hours. And we leave it in for the day, and we do serial platelet counts, and as soon as it comes comes up above 70, we'll take it out. And typically they do, even when it goes down into the 20,000s, a day or two, and it will be back up enough that you can pull it. Now, if it is a low platelet count because of dilutional, because there was hemorrhage or whatever, that's going to come back up again probably in a shorter period of time. But you do have to get serial platelet counts to take it out. I have never given a platelet transfusion to take a catheter out on an obstetric patient. I don't know if any of my colleagues have done that with epidurals for post-op pain and other procedures, but I've not had to do that in the obstetric population because it's usually HELP syndrome and it's a self-limiting thing.
Okay.
In the second lecture, in the supermorbidly obese, if you're placing the epidural and you get a wet tap, you go right to an intrathecal catheter, and if so, what doses do you typically use in an IT catheter?
Well, that depends on whether I'm patient or a resident. If I have a resident who gets a wet tap and it wasn't quite that hard, I'll go ahead and start again, especially if she's a prime and she's 1 centimeter. Because an intrathecal catheter will routinely get tachyphylaxis by the time she delivers 18, 24 hours later. On the other hand, if I'm placing it and I get a wet tap, it was hard. It was really hard. And then we would use an intrathecal, we have what we call a labor spinal, which is the dose of width in that. When we had sufentanil, we would have in that syringe 5 mics of sufentanil, 2.5 milligrams of isobaric bupivacaine, and that would be a bolus. And then we make that same infusion, our pharmacy makes it, over, it would be 0.5 milligram per cc of bupivacaine and 1 mic per cc of sufentanil. And then we run that at 5 cc's an hour, and that usually maintains them. Giving boluses every so often, if it breaks the pain of a cc at a time of 0.25% of bupivacaine, keeping in mind every time you bolus, you must give a cc of saline afterwards because our epidural catheters have a dead space of about 0.4 mLs, or almost half a cc. So when you inject, half is still in the catheter if you did flush it. Now that we don't have sufentanil, and God knows if we're ever going to use that, that's just a crime. But we've changed it to fentanyl 2.5 mics per cc and our 0.5 milligrams per cc of bupivacaine. So our labor spinal will have 12.5 mics of fentanyl and our 2.5 milligrams of bupivacaine for the bolus.
Okay.
Did you ask, I'm sorry, what? If you needed to dose it for a C-section, nothing hyperbaric in it. Yeah, and we usually use bolus.
Our beautiful sisters.
Every couple of minutes and
Okay, we have a question. Oh.
Significant tachyphylaxis. I had one person who had an intrathecal catheter for 24 hours, and they finally called a section. And so we are an institution where our sections take a long time. So our hyperbaric bupivacaine for single shot spinals, we're using 15 milligrams. I know a lot of people are not. For this lady to get a T4 level, I gave her incrementally 45 milligrams of 0.5% bupivacaine. And she moved herself over onto the table after the section 1 hour later because she had no walk. I mean, it only lasted an hour, so it was really impressive tachyphylaxis.
Yeah. We have a question over there first.
Thank you for the presentation. Question about neostigmine and atropine.
You got my question, man, I tell you. Sit down, will you? No, go ahead. I was just going to ask Dr. Washek about that too. Yeah, what's your experience?
It's the same question. Could you comment on this? I've been using it for conservative management of post-coital headaches.
Not at our institution. I don't know if you guys have any experience with that.
Yeah, I used it twice, and I was stopped by the hospital because they say that I'm going off label. But the neostigmine, as you all know, stimulates the choral plexus and increases the CSF flow, right? So you have to use atropine or glycol, because otherwise you'll have a lot of complications from neostigmine. But they say that patients are free from their post-dural puncture headache with 2 doses. But in my institution, I tried it with my residents, and there was only 1 dose. I don't know if it was, there were, one was a Spanish-speaking person now, and the other one was Chinese. So a lot of them also, I think, want to be with their babies, right away. It's like, yeah, it worked. Probably, so I don't know, but they stopped me. They want, an actual study case, with all the research board, and all that. So I thought, I didn't know it was a research drug. I said this drug is cheap and all this Methuselahs, but I don't know. What, anybody else with any experience on neostigmine?
Yeah, just a few times. But it seems like it could be part of a regimen when you're doing your conservative management.
Right.
So
Yeah.
if you're going to be watching these people in the hospital for 24 hours, it seems like there might be some benefit there for a more invasive process.
Yeah. In one patient, in the Chinese lady, no, none of these were my patients, by the way. These are colleagues that were going, I don't know what to do. It's like, oh my gosh, I already give him I think 20 cc's of blood through an epidural patch, and I go, oh, okay. And the other one was also a patient that refused, the epidural patch, the lady who was Chinese speaking, and I thought, well, let's try this. I've been teaching my residents about this, and let's try it, right? And it worked with only 1 dose, but in the literature it says that it takes 2 doses. I don't know if you,
You said in the article, right?
yeah.
Most people have complete resolution after 2.
Yes, that's what they say. So I was like really excited, I was like those guys, like, here come to save the day, and it did. But the nursing staff reported me, I guess, and then I had a whole bunch of people that came to my office, and I thought, oh wow, I'm popular. The pharmacist, the head pharmacist was there. The OB nurse in charge was there. Everybody was there. It's like, you need to stop this. And I thought, what? Stop what? That neostigmine, huh?
Those are drugs you never use.
I'm telling you, I was trying to tell. I even joked with the pharmacist. I said, hey, with this, we're not using neostigmine now. Let's put them to work, to some of their use, So, but they didn't find that too funny, actually. So I have something in my record now. So, okay, a question there?
Yes, I was, that's okay, emergency medicine doc here.
We love you.
When they come to our emergency department for conservative treatment, in addition to a liter of IV normal saline, Toradol if it's not contraindicated, I give Furacet.
Oh, yeah.
2 tabs of Furacet, which has the technique in it. And I think it's an oldie but goodie. There's Furacet for all kinds of headaches that come into the department still. And, it seems to
Help. Well, it's funny because the lady that I talked to you about, the Chinese-speaking lady who refused the epidural blood patch, was actually taking the same protocol that you were having, I guess, from the ER, and it was not helping her, So okay, we have another question in this side, then, huh?
I was actually wondering,
Just as a little aside, I would like to kind of share a case that my boss, asked me to evaluate. And this patient was morbid obese, and they were, whenever they tell you they're getting copies of the record, and it's like, oh my gosh, thanks a lot. So I'm going to be reviewing a legal document now here. So I kept on going around and trying to find what the score is, and it turns out that they were blaming us, because the epidural was too dense, they said. And this patient was trying to walk, I guess, after delivery, and she kept on falling. And I said, why in the world are you guys letting her walk then? You know, it's like, um, you know, our OB nurses over there, sometimes they take too many long breaks. But I said, you know, how come you're letting this patient walk? You know, so I had to go over there and try to talk to this really belligerent patient, and her husband was even worse. You know, we're gonna sue you guys. I said, well, I'm here to try to find out what's going on. You know, so we, my resident, and I, you know, did a neurological exam, and sure enough, she had, you know, some weakness, you know, flexing her, you know. So anyway, I was like racking my brains, you know, trying to find out. The epidural has been pulled out. You know, how can she have any more weakness? It's gone. You know, this epidural is gone now. You know. So anyway, let me finish this, and then I'll let you. And so anyway, as it turned out, I was looking at the record, and you know, for morbid obese patients, right? And this lady was put on Trendelenburg, and the delivery time was over 2 hours. You know, it was like maybe 2 hours and 40 minutes or something like that. And it's really kind of sad, you know. But the lady was falling down because bilaterally she had this weakness, right? And so then before she gets discharged, you know, she's talking to a nurse who was actually reporting it too, you know, everything that she was saying. And she said that she had a abdominoplastic, you know, bilaterally also. And at the end, she had the same thing. So I thought, wait a minute. This is kind of interesting because, you know, I was going to blame it on the fact that, you know, she was on Trendelenburg for over, you know, 120 minutes, you know. So there's case reports that show that at 90 minutes, people get bilateral compartmental syndromes, you know, and of course the femoral nerve is involved in that. And so I was going with that, but at that point in time when she said that, I was like, wait a minute. This sounds very suspicious to me. If you had, you know, abdominoplasty before at a ENT guy's office, that now you report that you had the same kind of weakness, you know. So I don't know. I was just gonna throw it at you guys there, and you know, what do you think is going on here? Go ahead, sir.
Often they put those patients in stirrups, and you'll get bilateral nerve damage just from being in the stirrups.
Yes, that's what the report said. You know, that I was reading a whole bunch of reports from Trendelenburg being, you know, one of the causes of compartment syndromes. But, you know, I don't know about how many of you guys are in private practice. I'm no longer in private practice. I'm teaching. And I'm telling you, especially when they're doing robot assisted, you know, they're there for like 5-6 hours on Trendelenburg, you know, and these patients are morbid obese, you know. So I'm really surprised that we don't have any more reports of compartment syndrome, you know. So anybody else help me with my report? I'm just concluding that, you know, since she had it before, this is something that was just exacerbated, you know, by Trendelenburg positioning, you know. So okay, anybody else? Oh yeah, I'm sorry. Anybody else? Thank you so much for attending and listening to these wonderful people.